Hi, my dear FMG friends. Myself, Dr. Aadil saying. Today, I am going to start with Pharmacology Super Revision session for the FMG 30th July examination. And this session is going to be worthy for your exam. And I expect most of the questions will be asked from this session. Do this session very well, and you will be good to go for the exam. So, let's start. Antithyroid drug of choice in the first trimester is propyl thiouracil. Carbimazole and methimazole, they are drug of choice in second and third trimester of pregnancy but are contraindicated in first trimester of pregnancy. Why? Because they lead to a malformation known as aplasia cutis. Aplasia means not produced, cutis means skin. As you can appreciate here, there is a scalp of a baby and the skin is not produced here, and this is the case of aplasia cutis. We have one radioisotope known as iodine 131, and it's very important. Its half life is 8 days and it is used for thyroid cancer. We know in hypothyroidism there is increased TSH level, and in hyperthyroidism there is decreased TSH level. In hypothyroidism we have to supplement thyroid hormones. How we treat it? We have to start L-thyroxine, that is T4. The dose is 25 micrograms daily, and gradually we increase the dose. Again, start levothyroxine 25 micrograms daily and gradually increase the dose. What is peripheral conversion of thyroid hormones? Is the conversion of T4 into T3 by the help of an enzyme known as 5' deiodinase. The drug of choice for thyroid storm is propranolol, which is a beta blocker. We have some anti-smoking drugs. Remember a mnemonic for them: nicotine very bad. N for nicotine replacement therapy, V for varenicillin, B for bupropion. The question can be asked: which antidepressant drug is used as an anti-smoking drug? That is bupropion. Varenicillin is most potent drugs in the anti-smoking drugs, and it is FDA approved drug. Now let's see another important topic, that is tumorlysis syndrome. In tumorlysis syndrome, what you have to remember is, if a patient is having cancer, we know there will be lot of tumor cells. For that we are giving anti-cancer drugs. Once we give anti-cancer drugs, these anti-cancer drugs are going to destroy these cells. Once these cells are break down, they are going to release excessive amount of DNA, and this DNA is going to be metabolized into the hypoxanthine. This hypoxanthine is going to be converted into uric acid by the help of an enzyme known as xanthine oxidase. This uric acid is harmful substance and it should be removed from our body. Our body removes it through the kidneys. Okay. But in birds, there is an enzyme known as uric acid oxidase. This uric acid oxidase is going to convert uric acid into allantoin. This allantoin is harmless substance. Okay. As you can appreciate here, in the cancer, there will be in the cancer patient, if we are giving anti-cancer drugs, there will be increased level of uric acid, that is hyperuricemia. Here you need to remember electrolyte imbalance in the tumorlysis syndrome, which is very important and can be asked in your exam. As I have told you, there will be hyperuricemia, that is a case of gout. And we know in the DNA we have phosphate group, that is phosphorus. If I have told you that tumor cells are going to release excessive amount of DNA, there will be excessive phosphorus as well, excessive phosphate as well. In the cells there is sodium, in the cells there is potassium also. Once these cells are break down, they are going to release excessive amount of sodium and potassium, and therefore there will be hypernatremia and hyperkalemia. But remember a very important, there is hypocalcemia, and this is the exam question which has been already asked in your exam. Now let's see gout. In gout, we have hyperuricemia, increased level of uric acid, and there is involvement of grade 2. Remember, aspirin is contraindicated in gout. Why? Because it is going to increase the uric acid level. That's why it is contraindicated in the gout. I have told you in the gout there is involvement of grade 2. As you can appreciate in this image that grade 2 is involved and can be given in the exam. And also in X-ray you can see here the grade 2 is involved. Now we have gout and pseudo gout. Gout is caused by deposition of sodium urate crystals, and pseudo gout is caused by deposition of calcium pyrophosphate crystals. These sodium urate crystals are negatively birefringent and calcium pyrophosphate crystals are positively birefringent, and they are needle shaped crystals and they are rhomboid shaped crystals. In gout, mostly big toe is involved, and in pseudo gout, mostly knee is involved. But remember, in gout, knee can also be involved. As you can see here, these are the needle shaped crystals in the gout, and in pseudo gout, you can appreciate these are the rhomboid shaped crystals in the pseudo gout. Now let's see some drugs. This xanthine oxidase, we know we have one enzyme known as xanthine oxidase. If we inhibit this enzyme, can you see here, once we inhibit this enzyme, it's going to inhibit the formation of uric acid. It means the hypoxanthine is not going to convert into uric acid, and therefore we prevent the excessive formation of uric acid in the gout. So xanthine oxidase inhibitors are allopurinol and febuxostate. We have other drugs as well, that is uric acid oxidase enzyme. Uric acid oxidase enzyme is a recombinant enzyme which we can give like pegloticase and rasburicase. This pegloticase or rasburicase, they are going to convert uric acid into allantoin. I have told you allantoin is a harmless substance. Remember, these enzymes, that is these drugs, pegloticase, rasburicase, they are fastest acting drugs to reduce the blood uric acid levels, and these drugs can be used in the tumorlysis syndrome as well, and these are the best drugs there. We have another group of drugs, that is uricosuric agents. Uricosuric agents are going to inhibit a transporter known as OATP urate transporter. Once this transporter is inhibited, there is increased excretion of uric acid in the urine. There is increased excretion of uric acid in the urine. The drugs include probenecid, sulfenpyrazone, lasinurad. These are the important drugs which you have to remember, and the probenecid, which is already asked in your exam. Now, remember, we have acute gout and chronic gout. In acute gout, the drug of choice are NSAIDs. Among NSAIDs, we use indomethacin. If NSAIDs are ineffective or contraindicated, then we can give steroids or colchicine. This colchicine is most effective drug in the acute gout. In chronic gout, the drug of choice is allopurinol, which is xanthine oxidase inhibitor. If there is no response to allopurinol, Then add uricosuric agents like probenecid. If still there is no response, we can start IV pegloticase monotherapy, which is a recombinant uric acid oxidase enzyme. Okay. Now, let's see a question. This question have been already asked in the FMG exam. A known hypertensive patient come to the emergency with complaints of palpitations, shortness of breath, with the blood pressure of 220 by 140. Which drug should not be used in this patient? This is the case of hypertensive emergency. Why? The BP is more than 180 by 110. In the hypertensive emergency, there is BP more than 180 by 110. In hypertensive emergency, we use IV sodium nitroprusside. We also use beta blocker like esmolol. We also use IV nicardipine, but we don't use IV mannitol. This mannitol actually is a osmotic diuretic. What it is going to do? It is going to increase the plasma volume. Once the plasma volume is increased, it is going to increase the blood pressure. Therefore, it is not given in the hypertensive emergency. Rather, it is going to worsen the hypertensive emergency. Remember, it is used in the cerebral edema. Okay. Also remember, it is contraindicated in active cerebral bleeding, also in left ventricular failure and pulmonary edema. In these conditions, it is contraindicated. Now let's see another important topic. This is the RAS system, renin angiotensin aldosterone system. We have to mainly focus on the drugs. Let's learn some basic idea about the RAS system. See, if in patient or any time the blood pressure falls, what is going to happen? In kidneys, we have some cells known as JG cells. JG cells. These JG cells contain a receptor known as beta 1 receptor. Once blood pressure falls, this beta 1 receptor is going to be stimulated. Once the beta 1 receptor is going to stimulate, it is going to, these JG cells are going to release an enzyme known as renin. Renin is an enzyme. It is going to convert angiotensinogen into angiotensin 1. Angiotensinogen is an inactive protein which is released from the liver, and it is going to be converted into angiotensin 1 by the help of renin. And this angiotensin 1 enters into the lungs, where it is converted into angiotensin 2 by the help of an enzyme known as angiotensin converting enzyme, that is ACE. Now what you have to remember, that this angiotensin 2 is going to act on its receptor. Angiotensin 1 receptor is present on the adrenal gland. Okay. Remember, angiotensin 2 is going to act on the angiotensin 1 receptor. Don't confuse. Angiotensin 2 is going to act on angiotensin 1 receptor. Once the angiotensin 2 act on the angiotensin 1 receptor, it is going to, this adrenal gland is going to release aldosterone. Okay. What this aldosterone is going to do? This aldosterone is going to reabsorb the sodium and water from the kidneys, and therefore will increase the blood pressure. Okay. Now, this aldosterone, excessive amount of aldosterone, is responsible for the left ventricular hypertrophy and can lead to death of a person. Okay. And this left ventricular hypertrophy due to excessive amount of aldosterone is known as cardiac remodeling. I hope this is clear. Now in your exam, the question is asked already that which drug works here. It means the drug which inhibits the formation of angiotensin 1 from the angiotensinogen. Now the drugs which work here are actually the renin blockers, which are inhibitors of renin. So you have to remember these drugs. What are direct renin blockers? The drugs include L-skyrine, remiskyrine. Okay. Remember, they are safe in diabetes mellitus. They are safe in diabetic patients. Rather, they are good drugs in the diabetic patients. But they are contraindicated in pregnancy. And as I have told you, once this renin is inhibited, this aldosterone will not be formed. It means there will be decreased aldosterone. And but also remember, it indirectly increases the renin levels. It inhibits the renin. Directly it inhibits the renin, but indirectly these drugs are going to increase the renin levels. I hope this is clear. Now let's see, in congestive heart failure, we know in congestive heart failure we have biventricular failure of heart. In this condition there is edema and breathlessness. In MCQ, if you see, there is a history of edema, breathlessness. Remember that is the case of congestive heart failure. As you can appreciate here, this is a pitting edema seen in the congestive heart failure. And also you can also appreciate clubbing of fingers in the congestive heart failure. Now let's see, what are the best drug for the edema in congestive heart failure? The best drug in the edema in congestive heart failure is furosemide. What is the mechanism of action of furosemide? It inhibits sodium potassium 2 chloride symporter. It inhibits sodium potassium 2 chloride symporter. And this furosemide or tosemide, they are loop diuretics. We are going to discuss loop diuretics. Every diuretic we are going to discuss. Let's see another topic here. The drugs which increase longevity in the congestive heart failure patients plus or decrease cardiac remodeling. The drugs which increase the longevity or lifespan in the congestive heart failure patients or decrease the cardiac remodeling or decrease the aldosterone production. The drugs are like beta blockers, AC inhibitors, angiotensin 1 receptor blockers, aldosterone receptor blockers. In beta blockers, which receptor we can target? This receptor. Once we target this receptor, once this is blocked, it means the aldosterone will not be formed. And second, what we can target is we can directly inhibit this renin. We have talked the drugs as well. Then we can inhibit this enzyme, angiotensin convertase enzyme. Then we can target this receptor, angiotensin 1 receptor blockers, or we can target aldosterone receptor blockers. These are the drugs which I have written here. Among beta blockers, we can use carvedilol, metoprolol. This metoprolol is already asked in your exam, that which drug increases the longevity in CHF patients. That is metoprolol. Actually, all these drugs increase the longevity. In AC inhibitors, the drugs are captopril, lisinopril. This is already asked. Angiotensin 1 receptor blockers are sartan drugs like losartan, valsartan, telmisartan, candesartan, and irbesartan. These are the drugs which can be used. Aldosterone receptor antagonists are spironolactone. Okay. Now let's see drugs used in acute CHF. The drug used in the acute CHF is digoxin. Okay. The side effect of AC inhibitors, angiotensin convertase inhibitors like captopril, lisinopril, what are the side effects? The main side effects which I want you to remember, that is cough and angioedema. As you can see here, this is the case of angioedema. This is the case of angioedema and can be asked in your exam. Remember this side effect, it is very important. Now let's see another important topic, that is Reynolds phenomenon. Reynolds phenomenon is also known as peripheral vascular disease. Let's see here, primary Reynolds phenomenon. There is primary Reynolds phenomenon and secondary Reynolds phenomenon. Primary Reynolds phenomenon is also known as Reynolds disease, and secondary Reynolds phenomenon is also known as Reynolds syndrome. Okay. What is Reynolds phenomenon? It is an exaggerated vascular response to cold temperature or emotional stress. This is known as Reynolds phenomenon. Exaggerated response to cold temperature or emotional stress. As you can appreciate here, there is the pallor first. Why? Because due to cold there is constriction of the blood vessel. Once there is constriction of the blood vessel, the blood flow to the affected area will be very less. As you can see here, this is the pale area here due to less blood flow, and then cyanosis is going to occur. Why? Due to tissue hypoxia. And then rubor is going to occur. Redness is going to occur. Why? Due to the reperfusion of the affected tissue. As you can see here, the redness is occurred due to the reperfusion of the blood to the tissue. Now, if you want to crack this MCQ, in the question there will be given history of a female washing clothes. And as I have told you, there is primary Reynolds and secondary Reynolds. Primary Reynolds occurs alone. There is no evidence of associated disorder. Okay. Secondary Reynolds is associated with some illness like SLE, systemic lupus erythematosus, systemic sclerosis, dermatomyositis, Sjogren syndrome, rheumatoid arthritis. Okay. Remember these are the MCQs. In treatment, what we give calcium channel blockers. Once we give calcium channel blockers like nifedipine or amlodipine, they are going to dilate the blood vessel. Once the blood vessel is dilated, the blood flow to the affected tissues will be there. Okay. Now we can also use sildenafil, which is an alternative of the calcium channel blockers. But calcium channel blockers are the good drugs in the Reynolds phenomenon. Now let's see, guys. We have opioids. In opioids, let me select another color. In opioids, we have like morphine, heroin. What is the mechanism of action of opioids? They are going to stimulate mu, kappa and delta receptors. Once these receptors are stimulated, they are going to result analgesia, loss of pain. Okay. Remember tramadol. Tramadol acts via opioid as well as non-opioid mechanisms, therefore result analgesia. Opioid mechanisms, these are the opioid receptors. It will act on the mu, kappa and delta. But what are the non-opioid receptors by which they cause analgesia? They actually increase the 5-hydroxytryptamine levels and also increase the norepinephrine levels, by which they cause the analgesia, which are the non-opioid mechanisms by causing the analgesia. Now let's see another important topic. What are the side effects of opioids? For the side effect of opioids, you have to remember a mnemonic, that is sacrum. SACRUM, sacrum. As for sedation, they are going to cause sedation. And if there is toxicity of opioid, they can even cause coma to the patient. A for analgesia. Remember, they are not going to cause hyperalgesia. They are going to decrease the pain. C for constipation. R for respiratory distress. They are going to decrease the respiratory rate. U for euphoria. It is a euphoria. What is euphoria? Euphoria is a sense of well-being. M for meiosis. Even we can see pinpoint pupil. Pinpoint pupil. Now also you have to remember, if a person abruptly leaves the opioids, or if a person is going to withdraw the opioids, what is going to occur? In a patient, opioid withdrawal symptoms are going to occur. Instead of sedation, seizures are going to occur. And instead of analgesia, there is going to be diffuse body pain, that is hyperalgesia. In constipation, instead of constipation, there will be diarrhea. Instead of respiratory depression, there will be tachypnea. Instead of euphoria, there will be dysphoria. But remember, instead of meiosis, there will be midriasis, very important, that can be given in the MCQ. And once a person leaves any drug abruptly, what is going to happen? There will be increased sympathetic activity. In sympathetic activity, what is going to happen? There will be tachycardia, palpitations, and hypertension. These four important points you have to remember to crack the MCQ of opioid withdrawal. Okay, I hope this is clear. For opioid withdrawal, for opioid poisoning, the antidote is naloxone IV. Naloxone IV. It is used in the opioid poisoning, and it is the antidote actually. Now a patient with history of drug abuse presented to emergency in comatose state. The patient is in the comatose state. Here is history is given, drug abuse. Vitals are recorded were respiratory rate is 8 per minute, that is respiratory depression. The blood pressure is 90/60, hypotension. On examination, there was pinpoint pupil. It is enough to crack the MCQ. What is the poisoning agent? The poisoning agent is obviously opioid, that is morphine. Okay, I hope this is clear. The most potent opioids are fentanyl group of drugs, like fentanyl, L-fentanyl, remifentanil, sufentanil. These are the most potent opioids. Now let's see another important topic, that is Lamotrigine. Lamotrigine is an anti-epileptic drug. For this drug, we have to give the dose cautiously. That's why we do titration. Titration is done for this drug to prevent a skin rash. To prevent the skin rash, we do a titration. Okay, we gradually increase the dose of this drug. Now, what kind of skin rash can occur in the lamotrigine toxicity? This skin rash, if this skin rash covers less than 30% of skin surface, it is called as Steven-Johnson syndrome. If this skin rash is going to cover more than 30% of skin surface, it is known as toxic epidermal necrolysis. As you can appreciate here, this is the toxic epidermal necrolysis which has occurred due to lamotrigine. Now remember, Drug of choice for the mania and bipolar disorder is lithium. Drug of choice for mania and bipolar disorder in pregnancy. If question is asking in pregnancy, the drug of choice are antipsychotics. Antipsychotics like olanzapine, risperidone. They are the drug of choice. Why we don't give lithium in the pregnancy? Because it is going to cause some malformations, like it is going to cause Ebstein's anomaly. What is Ebstein's anomaly? It is tricuspid atresia in the fetus. Okay. For lithium, you have to remember side effects. Okay. Li. The lithium itself is a mnemonic for the side effects of lithium. Li means leukocytosis. Leukocytosis increase in the WBCs. T for tremors. Okay. And the most common, it is the most common side effect. Okay. You don't need to remember fine tremors, intoxicity and coarse tremors. Don't remember this. Remember, most common side effect is tremors. H for hypothyroidism. IU means increased urine, that can be seen in diabetes insipidus. You know that in diabetes insipidus there is increased production of the urine. Okay, so lithium can lead to diabetes insipidus. Okay, M for in mothers. If we use in mothers in pregnancy, if we use, it can cause Ebstein's anomaly, that is tricuspid atresia in the fetus. I hope this is clear. Now let's see local anesthetic toxicity. We have some local anesthetics like lignocaine, bupivacaine, lidocaine, and in MCQ you will be given bupivacaine history. Bupivacaine history. In local anesthetic toxicity, what is going to happen? There will be tachycardia, hypotension, arrhythmias, cardiovascular collapse. These will be the symptoms in the local anesthetic toxicity. What is the drug of choice for local anesthetic toxicity? Very important. The drug of choice is 20% intralipid. The drug of choice is 20% intralipid.